As a paramedic, obviously I've got first-hand experience of how chaotic my job can be. So I could be on a multi-vehicle RTC on the motorway, I could be at a house fire, I can go from one extreme to the other. Some scenes can be incredibly high adrenaline, they can be very, very chaotic. So we need a tool that can keep us on the straight and narrow and not allow external factors to influence or distract us. And that's where the primary survey, Dr. CABCDE, comes in.
With you saying that the internal bleeds, how would you recognise if there's an internal bleed?
So there's a number of ways that you can identify them, and again, this is something that we definitely go into quite significant depth on the courses. But for things like abdominal or pelvic bleeding, we're looking for deformity, guarding, rigidity, swelling, bruising, pain. But deformity, bruising, swelling, pain, rigidity are all the main sort of things that we're looking for. Hi and welcome to Basegreen's Clinical Podcast, episode number 2. I'm Ruth, one of the paramedic educators here at Basegreen.
Hi, I'm Ailey. I am not a clinician, but I am here to ask any questions that you as learners might want to know the answer to prior to starting a course.
Brilliant, that's great. Thank you so much for being here today, Ailey.
Thank you for having me.
So today we're going to be discussing a primary survey, one of the most important parts of patient assessment.
Okay, and what is a primary survey?
So a primary survey is quite literally what it says on the tin. Primary being the first, and survey, it's a checklist. So it's a formation of questions and checks that we carry out as clinicians or clinical supports or FRECs, whatever we want to call ourselves, in order to ensure that patients are being treated in a timely manner with identifying any sort of time critical or life-threatening injuries or illnesses.
And can you give me a basic understanding of what a primary survey entails?
Yeah, of course. So I think if you're already a student here at Basegreen, you'll definitely know, or you'll have definitely heard all the educators banging on and on and on about Dr. CABCDE. If you're not already a student and you're wanting to come to us, this will be a really handy tool just to get that prior sort of learning and knowledge in there. So it's an acronym, so each letter stands for a check or a question or an area that we need to look further into. So it's Dr. CABCDE. It used to just be called ABCDE, and the more that medicine sort of evolved and developed and we sort of review serious incidents and things like that, we've realised that actually we need to expand it. So it's now Dr. CABCDE. So a primary survey is used as the initial tool when you're assessing any patient. So that could be medical patient, trauma patient, or walking wounded, anything like that. So it's really important that we follow this stepwise approach with every patient so that we don't miss anything. As a paramedic, obviously I've got first-hand experience of how chaotic my job can be. So I could be on a multi-vehicle RTC on the motorway, I could be at a house fire, or I could be with a little old deer who's fallen. You know, I can go from one extreme to the other. Some scenes can be incredibly high adrenaline, they can be very, very chaotic. So we need a tool that can keep us on the straight and narrow and not allow external factors to influence or distract us. And that's where the primary survey, Dr. CABCDE, comes in.
And would you use every element of the Dr. CABCDE?
Yeah, brilliant, well done. You're learning already.
On every job, would you use every single
job, and sometimes multiple times in a job. So sometimes you need to circle back and start again. Sometimes you might have more than one patient, and sometimes, like I said, you just need to reassess. So we can sort of go through each step, and then if you've got any questions, ask away, because I'm sure, as you've not yet done your FREC 3 or 4, the questions that you have will really help the learners, won't they? So the D stands for danger. So when you're approaching any job, it's really important that I keep myself safe. I'm not going to be able to help anybody if I come in harm's way. And it's the same for my crewmate. So everybody is performing a dynamic risk assessment, so making sure that there's no danger there and it's safe for us to approach. But it's also being aware of what dangers may present. So it's current dangers, current hazards that may develop or that may be potential. So depending on what scene you're at, what environment you're in, really does depend on what potential hazards you may come across. Car accidents, for example, is the lane live? Is there still traffic moving near you? Has the road been closed? If it's a car accident, is there fuel on the road? Are there fumes? Or if you're in a nightclub and you're attending someone who is either fallen or intoxicated or a fight, really common scenes for us as paramedics. Is it safe to approach? Is there large crowds? Is there glass on the floor? Am I going to slip? Am I going to trip? Those sorts of things. So really taking a step back and assessing the wider scene. Is it safe for me? Is it safe for my crewmate? And is it safe for my patient? And what can change? So that's first and foremost what we need to be doing prior to attending that patient and physically getting to the patient. So that part of the primary survey can start as early as in the ambulance en route to the patient, or when you're at scene, or if you're in an event when you first get that call on the radio that someone's fallen, when you're walking up to them. It doesn't have to be when you make that patient contact. Any questions?
No, I don't think so. I think a lot of that will resonate with a lot of people who have done first aid at work. Anyway.
Yeah, exactly. And I think that's it's quite an understandable part of the process, because when you're out in a pre-hospital environment, there are dangers, and I think people do resonate with that just from day-to-day life. You know, if you're going to cross a road, you do check both ways, don't you? Exactly. It's the same sort of thing. So then we go on to the R, which is obviously of Dr. CA, BCD, the R, and it's for response. So very much is there a response? Is there a response of the patient? Now, the more experienced you become as a clinician or as a FREC clinical support, the more this becomes real second nature. You don't always need to stand there and go, Dr. CA, BCD in your head and, you know, work it out as you go along. It becomes very, very natural. So I'm 9 years in now, and it's not often that I go, right, Dr. da-da-da-da-da-da-da. I'm very much like, I've got my own way of doing things, and it just so happens that my way of doing it fits in with that process. So you're looking for a response. Now, a little sort of pointer of the response is you need to be aware that not everybody can hear. So you need to make sure that you're trying to gain a response from the patient in a way that is covering all bases. So I always tell my learners, whether that's in the classroom or the students that I have when I'm out on the road as a paramedic mentor, that try and, if possible, approach from the foot end of the patient. Now, if we say the patient's on the floor, that's even more so important. If a patient's sat down, try and approach them from their line of sight. And now this is especially important in patients that have experienced a traumatic injury. If we're approaching from the head end where the patient can't see, and we say, hello, my name's Ruth and I'm a paramedic here to help you, and they go like this, and just for those who are listening, I've just turned my head, it's causing them further movement, and sometimes we really need to encourage patients to stay still. Also, depending on the patient and depending on the environment, we don't want to startle people or make them worried, you know, cause anxiety or to any vulnerability. So approaching from line of sight is really, really important. Simple words such as, hello, my name is, for Ruth, I'm a such and such. It's really important to identify yourself as your role, and I'm here to help you, and see if the patient responds. If they don't respond, you then need to ask them a direct question to ensure that they weren't just listening and didn't realise that they needed a response. So, can you tell me your name? Is a really good one. Or please, can I ask your name? And it also helps break down barriers, so, you know, building up that rapport with the patient. But always introduce yourself and then try and gain a response from the patient, preferably a verbal response. If the patient then doesn't respond verbally, we are becoming aware that this patient may be more significantly ill than someone who can respond. So walking up to their shoulders and doing a slight tap on their shoulders. Now, I don't want any sort of pressure point application or anything like that. Just a nice pat on the shoulder or slight shake of the shoulder and say, hello, can you hear me? And wait for that response. If there is a response, then obviously you'd note that, and that would help form your general overall opinion of what's going on. And if there isn't a response, then we're considering, is this patient unconscious? We can't move on to the next step of the Dr. C, A, B, C, D, E process until we've completed that one. So you can never move on to the next letter until you've done the first one. So we'd always need to ascertain if we've got a response of the patient. And whether we do or we don't doesn't change the fact that we're going to go on to the next step. It's just important that we're gathering that information so it can help us build, you know, that image of what's going on with the patient. So that's doctor done. So it's danger and response. So that moves us nicely onto big C. So we call it big C because in this process there are two C's. So it's either first C or big C. But big C is quite appropriate because it stands for catastrophic hemorrhage. Have you heard of that before?
Yes, I've heard.
So a catastrophic hemorrhage is a significant bleed, serious bleed, that will end life within seconds or minutes if not intervened with, if not treated. So the way that we look for a catastrophic bleed is we can use a saying called blood on the floor or 4 more. And now that just helps to keep us in line with where we're checking. So blood on the floor, we're looking, is there any blood visible to us? Can we see blood on the floor around the patient? Are they wearing blood-stained clothing? And then the 4 more. So we do a quick check of the abdomen, the chest, the femur, and the pelvis. So these 4 areas are areas where internal bleeding can occur and can occur extremely seriously. Due to the blood supply in those areas, obviously with your femur, which is a bone at the top of your leg, we've got our femoral artery, but it's also the biggest bone in the body, so it's got an enormous blood supply. So we can lose an enormous amount of blood in that area very, very quickly. So we're looking, is there any blood around? Is it spurting? Is it oozing? Is it pulsing? Or checking those 4 areas for any signs of internal bleeding. If we have an open bleed, so when it's spurting or we can see blood, then we'd need to be applying a catastrophic tourniquet, or CAT tourniquet, as more commonly known as. Now, this is a medical intervention. There are steps to it, but we're going to discuss that later down the line in the podcast about how we'd put one on and what it is. But it's just important to know that here we're looking for catastrophic bleed. If we find one, we must treat it before we move on to the next step. So we'd apply a tourniquet and then we'd move on. We'd stop the bleeding and then we'd move on to the next step.
Okay, and with you saying that the internal bleeds, how would you recognise if there's an internal bleed?
So there's a number of ways that you can identify them. And again, this is something that we definitely go into quite significant depth on the courses. But for things like abdomen or pelvic bleeding, we're looking for deformity, guarding, rigidity, swelling, bruising, pain. The same with the legs, the femur, you tend to see extreme swelling and deformity of the femur. And then with the chest as well, it can be that the chest isn't moving equally, one side's not moving properly, or the breathing is very, very shallow. So there's lots of indications of them, but that'll be discussed in the courses in more detail. But deformity, bruising, swelling, pain, rigidity are all the main sort of things that we're looking for. And that takes us quite nicely onto A. So this is where it tends to get a little bit more into the flow of things. So the next one's airway. So we need to make sure that a patient's airway is clear and patent before we move on. And that's because if their airway is blocked, they can't breathe, they can't get oxygen in, can they? So what we would do is if the patient was unconscious, we would open their mouth, and there's 2 ways of performing this. There is the head tilt chin lift, which is you place 2 fingers on the top of the forehead and 2 fingers under the chin, and you tip the head back into a sniffing of the morning air position, and that'll allow the airway to come into a neutral position and become open. However, if the patient's a trauma patient and we're thinking they might have broken the neck, or there's a possibility of that, then obviously moving their head backwards will move their neck, could cause further injuries. So we would use something called a jaw thrust. And this is where we place fingers or thumbs behind the bottom part of the jaw and we push it forwards, which will then open the mouth and allow for the airway to be then opened.
Okay.
So for an airway assessment, we need to be opening the mouth. We want to be, if it's not already, having a look in the airway to make sure there's no signs of any blockages such as a foreign body or vomit. And if there is, that would need to be cleared. Now, you can use suction devices, McGill's, or a gentle finger sweep to remove anything from the patient's airway. However, you can only ever do it to line of sight. So you can only ever put anything where you can see it. We don't want to be fishing down the back of the throat. And that's not just for FREX, that's for paramedics too. We don't do blind extraction.
Okay.
If the airway is not patent, so say it's clear, but they're making grunting noises or snoring noises, so that at some point their airway is compromised, we can then use things like oropharyngeal airways or nasopharyngeal airways, which are small plastic tubes that are inserted either into the mouth or up the nose, and that will then provide some external stability, plastic tubing that opens the airway and keeps it open. And these can be inserted, and for an OPA and an NPA, which is the acronym for the devices that I've just spoken about, are taught on FREC 3 and FREC 4, and they can be carried out by both staff grades.
Okay, that's great.
So once we're certain that the patient's airway is clear and patent and it is being maintained, we can then move on to our breathing assessment.
Yep.
So it's really important that we understand why we're doing a breathing assessment and what we're looking for. I feel like students sometimes get a little bit flustered with their breathing assessment because it's the part of the assessment that contains the most steps, especially when it comes to trauma. For this discussion, we're just going to focus on the medical patient for now, and podcast 3 will go into more detail about the traumatic assessment. So with breathing, we're looking at are they breathing? Because that's a big one. If they're not breathing, then we're going to consider it's cardiac arrest and start CPR. But for the sake of today, patient's breathing. So we want to be looking at how are they breathing, how fast are they breathing, or how slow are they breathing. We could put a pulse oximeter on. Have you heard of one of those?
I have heard of
them. So for those who are watching, It's one of these. It's just a
Yeah.
clip that goes onto the finger, and it will then give us a number.
Yeah.
Having our oxygen saturations can give us an indication of how well we're breathing.
Yeah.
So we're looking at the rate of resp, so how quickly or how slowly, their quality. So are the breaths shallow? Are they laboured? Are they quite exaggerated? Because again, if there's anything abnormal about their breathing, that can indicate that we've got something going on a respiratory level. We're also wanting to be knowing about additional sounds. So is the patient wheezy? Or are there any other noises that say we wouldn't expect to hear from a patient? Wheezing is probably the most common one that you can hear in a primary survey, because we don't need to use a stethoscope necessarily to be able to hear that. So rate, rhythm, depth, essentially, of respiration, and then move on. So obviously if we found a problem, so if we found that their oxygen levels are really low, then we need to be intervening before we can move on. So we'd apply oxygen. But other than that, we do a basic respiratory assessment, and then we can move on to circulation.
Okay.
So once we've ensured that their breathing assessment is thorough and we're happy that their breathing has either been dealt with in terms of we've provided them with some support or intervention, or that it's adequate without intervention, we can then move on to the next C. So little c. Now little c is it's still very, very important, but obviously a catastrophic hemorrhage, like I said, can end life within seconds or minutes. So it's important that has that priority. So little c is circulation. Now, circulation assessment in terms of a primary survey is, for me when I'm teaching, I always say, let's check their radial pulse. Now, when you touch someone's radial pulse, you're touching their skin. So you can get so much information from one very simple movement.
Yeah.
Because you're touching the skin, you can feel the temperature of the skin, the colour of the skin. Is it sweaty? Is it clammy? But then obviously you're feeling the pulse. Is it regular? Is it fast? But also, how is the pulse feeling? Is it thready? Is it weak? Is it bounding? So we can get so much information from just simply feeling the pulse on a radial, finding the radial pulse. Also, if we can't find a radial pulse, if the patient hasn't got one, then we know there's something wrong with their circulation system, their blood pressure's low. So it gives us a huge amount of information. So that's definitely one thing I'd say to the learners or for yourself, is just don't forget that something as simple as 2 fingers on the radial pulse can teach us so much.
And just for those that aren't clinical, what is a radial pulse?
Just on your wrist. So at your radius, just below your wrist line, there is a pulse there. Most people will have definitely felt it at some point, but if you take your index finger and your middle finger and you just place it slightly below your wrist, just on the side of your thumb, and move it down until you feel a pulse. Now, one thing is, don't press too hard, because you can occlude your pulse. If you put too much pressure on it, it'll occlude it, so then you can't feel it. And I don't want people getting panicked. Just two fingers gently on the wrist.
I don't think I've got a pulse.
I'm sure you have. So you probably just, if you move it a little bit further over this way, there we go. Just pretend, woman.
Yes, I can feel a pulse.
So have you got a pulse?
I've got a pulse.
Excellent. So yeah, we can gather so much important information from just taking a radial pulse. Now, we're wanting to note here their heart rate, how their skin appears, the temperature. Not only do we need to check the pulse for the rate, the rhythm, the depth, the skin quality and temperature, we also need to carry out a capillary refill. Now, this is to ensure that we've got adequate perfusion. Now, for those non-medical people, or people who may not understand what that means, is it's ensuring that there is a satisfactory amount of blood flow. So if we've got a sudden loss of blood pressure or fluid volume, then we wouldn't be adequately perfused, and this is a test that can tell. And it's very, very simple, and again, listeners at home can have a go on themselves, or a friend, with consent obviously, just to understand what I mean. Now, we've got 2 types of capillary refill. We've got central and peripheral. So central being our head and trunk, and peripheral being our extremities such as our fingers or toes. So if we just talk about peripheral for now, is you would press down on the nail bed for 5 seconds, and then release, and you'll notice that your pink nail has gone white and then reduces back into a pink colour. The capillary refill is the time that it takes to return to that original pink colour. For a central one, you do it on the chest or the forehead. I personally prefer to do it on the chest. I just press in again, very gently. We don't want to be poking and stabbing. It's just gentle pressure for 5 seconds, and then releasing, and we're waiting to see the colour return back to the usual skin tone of the patient. And again, this should take less than 2 seconds. Any longer than 2 seconds, we are concerned about a circulatory problem.
Okay.
And the other thing that we need to do at the second C is if we've applied a catastrophic tourniquet on the big C, the first C, we just need to recheck it and make sure it's still sufficient and it's still working.
Okay.
Once you've done those 3 things, we can then move on to D. Any other minor bleeds can also be addressed here as well. So something that's not catastrophic but may need intervention can also be addressed at circulation. And once you've concluded those checks, that's C done with, and we can move on to disability for D. So here we're going to be looking at their level of consciousness. So there are 2 tests that you can do here. You should only be doing the one that you are most comfortable with. So as a paramedic, I'm very, very comfortable with carrying out what we call the GCS, which stands for Glasgow Coma Score. I'm very comfortable with this because I've done it day in, day out for a number of years, whereas students often find it quite flustering and quite complicated when they first start with it. So only do a GCS if you're happy with it. Now you can find out more about what a GCS is externally. I'm not going to go into it now because it's quite thorough, but it's essentially assessing someone's eyes, voice and motor skills to ensure that they are responding appropriately. Now, the more sort of simpler or quick and dirty way of doing it is called an AVPU. So is a patient alert? Are they responding to voice? Are they responding to pain or pressure? Or are they unresponsive? So there's only really 4 options.
Yeah.
That being said, we're going through a change at the moment where we're actually adding a C in between the A and the V. So it's now alert, confused, voice, pressure, unresponsive. And that's because some people can be speaking to us but be confused, so therefore they're not alert, they're not their usual self, but they're not unresponsive either. So there's also confused in there as well. So when we're using the AVPU, if a person is alert and responding appropriately, then we know they are the A of AVPU. Whereas if they are a little bit confused or maybe not responding verbally appropriately, they're groaning and coughing and saying confused words and they'd go down as confused. Whereas if they weren't responding in either of those 2 categories, I could go, oh, hey, Ailey. And then if you went, oh, hi, and responded to me, you would then be down as responding to voice. However, if you then didn't reply back to me, I would apply pressure stimulus. So it used to be called pain, but obviously we don't want to be inflicting pain to patients because that's not what we're here for. We're here to preserve and encourage healthy life, not cause issue and illness. So things like a gentle pat on the shoulder or a gentle squeeze of the shoulder can be absolutely fine and appropriate. If there's still no response to a pressure stimuli, then we'd be saying that this patient is unresponsive. So at disability, we want to be double checking their AVPU or GCS if you feel comfortable and confident to do so. Another thing in the disability assessment that we need to be looking at is the pupil response. So are our pupils equal and reactive to light? So if you ever hear the word pearl in any sort of medical circumstance, it means pupils equal and reactive to light. So our pupils are meant to be equal and they are meant to react to light. Any changes to that, we've got an indication of a potential head injury. So that's another thing that we check for at the disability stage. And also we can check for blood sugar levels, using a finger prick test. And that can also be done here if indicated. Now, it's not routinely indicated, it's only in certain circumstances, which again, we can discuss later on. That then takes us nicely on to E, which is expose and examine and consider environment. So we are exposing the patient to ensure that we've not missed anything. We are considering the environment that they're in. Has anything changed? We need to protect them from the environment, check the temperature and bits and pieces like that.
Okay. I do have a question on the disability one because I'm presuming it's quite patient specific because a lot of people have underlying issues, so like dementia, that would come across as someone might be quite confused. How would you differentiate it in the
so like how would you know when to treat it, sort of thing? So if someone's got a cognitive impairment, whether that's dementia, a mental health illness, it's a cognitive impairment due to intoxication or whatever, we still need to assess them and treat them. So if it's someone who's living with dementia, then we would still write down what we see. So if they still present as confused or responding only to voice or alert, we would write that, but then we would write that that's their baseline due to dementia or whatever the cognitive impairment it is. It's very important that we don't write that they're alert unless they are alert and responding appropriately. Because if we write that someone is alert because that's their normal, but we don't mention that that's their normal, and then we take them to secondary care and someone comes and sees them and they are presenting in a confused manner, that's showing deterioration that actually isn't there because the patient was always like that. So we always write whatever we see, but if it's due to a condition such as dementia, write in your paperwork that they are confused on the AVPU, but this is their baseline due to cognitive impairment.
Okay.
Lovely stuff.
Cool.
So that's like a general overview of the primary survey. Have you got any questions?
So there's quite a lot that you've got to kind of do in the first instance. How long do you do that for? Like, how long does it normally take?
Brilliant question. So I appreciate that it's just taken a good few minutes for us to get through it, but 60 to 90 seconds top to bottom.
Okay.
It's really quick. And like I said, the more experienced you are, the easier it is, and the more you do it, the easier it is. And that's why on our courses at Basegreen, we really do sort of drum it in to students, you know, this is so important. Every time we're talking about a scenario, I will make my learners go through Dr. C, A, B, C, D, even if we're just discussing something, because you have to get used to it. Yeah. And like I said, the more experienced you are, the more you'll become into a bit of a flow rhythm with it. So, for example, for me, when I'm approaching a patient, when I've deemed it safe to do so, I will roll my response into my airway assessment. I'll be approaching and saying, hiya, my name's Ruth, Yeah. And I'm already looking at their mouth. I'm looking at, is it open? Like, how are they breathing? Is there additional airway noises? Are there signs of any vomit? So I'm doing them at the same time. And that's because I'm very comfortable with that system. However, there's no shame in not doing it in that way. All we need to do is making sure that we do each step in a very sort of methodical manner to make sure that the patient is safe. Just to recap really quickly, as it was quite a long time ago that we spoke about the danger elements. So we'll just run through it again. And at this point, students can just re-listen to this a little bit if they want to just get it nailed down for revision. Yeah. So danger, potential hazards, current hazards, active hazards. Is it safe for me? Is it safe for my colleagues? Is it safe for the patient? Box that off, move on. Yeah. Response, is the patient alert? Are they unresponsive? Are they confused? How are they presenting? And if you can approach from the line of sight, that is much better for the patient. Catastrophic bleed, a bleed that can end a life within seconds or minutes if untreated. Check on the floor, check the pelvis, check the chest, check the abdomen, and check the femurs, because that's a long burn and that's where we can lose a lot of blood. If we find one, deal with it using a cat tourniquet at that point. Move on. Airway. Is the airway clear? Are they maintaining it? Is it patent? If not, is it blocked? Is there foreign bodies? Is there vomit? Are there any additional noises such as grunting or snoring? If so, intervene. Intervene by removing the foreign body and then placing in an adjunct such as an oropharyngeal airway or a nasopharyngeal airway. Once that's completed, move on. Breathing assessment. Rate of breathing. Is their breathing symmetrical across their chest? Are there any additional noises? How are they breathing? Is it laboured? Is it shallow? Is it fast? These sorts of questions. Any concerns, we need to intervene. Put a pulse oximeter on at this point. If their oxygen levels need administration of oxygen, intervene with that at this point. Move on. Circulation. Feel the pulse. Like I said, you can get so much information from just simply feeling a radial pulse. Make sure we're gaining consent before touching a patient at any point, obviously. But what's the rate, rhythm and depth of the radial pulse? Is it even there? How does the skin feel? Are they clammy? What's the temperature like? Then perform a capillary refill, centrally or peripherally. If the peripheral one is delayed, you must then complete a central one to ensure that that's not delayed, or if it is, note it down. Yeah. We want that to be less than 2 seconds. Any minor bleeds that need attention, deal with then. Move on. Disability. What's their AVPU? What's their GCS? Only do the one you are comfortable with. You don't want to be wasting time because this is a very quick assessment. Yeah. Pearl. Pupils equal and reactive to light. Take a pen torch, shine it in each pupil. Does it react to move? If not, note it down. Be aware there may be a head injury. Check a blood glucose level if indicated. Has the patient collapsed? Have they vomited? Are they confused? Are they intoxicated? It's just a non-exhaustive list of some reasons why you may intervene with a blood glucose. So once you've completed that blood glucose if indicated, move on. Expose and examine. Make sure that you've not missed any injuries, missed anything that needs further attention. You can either go back to the beginning and reassess using the primary survey, or we can then start our secondary survey at this point. It is a very, very quick, methodical way of assessing a patient so that we don't miss any life-threatening or time-critical illnesses.
Yeah, that's great.
Any questions?
No, I don't think so.
Awesome.